We have some distinguished federal officials from HHS presenting today on CARB, HIV, and sexually transmitted infections. So I'd like to begin introducing our first speaker, who is Dr. Jimenez Musmar. She's the designated federal official for the Presidential Advisory Council on Combating Antibiotic Resistant Bacteria, known to some of you as PACCAR. She has a distinguished career and holds a master's degree in biomedical science policy from Georgetown University and a doctorate in biodefense with a concentration in international and homeland security from George Mason University. So we welcome Dr. Musmar today, and I'm going to turn it over to you, Jimenez.
Thank you, Dr. Bolin, and again, a sincere appreciation for inviting our office to come and speak on the many activities that we're involved in. I'm going to pull up the slides for everyone to see so we can get started promptly. Hopefully everyone can see what I've got here. All right. Okay, well, thank you again. And I'm here to discuss with you the One Health activities that our office undertakes, and in particular, two bodies of federal work that contribute to the CARB effort within the US government. I'll be discussing with you the Presidential Advisory Council on Combating Antibiotic Resistant Bacteria and their input into the National Action Plan for Combating Antibiotic Resistant Bacteria that was formed by the Interagency CARB Task Force. So just a little bit about antibiotic resistance. As we all know, they're important tools for addressing bacterial infections in humans and animals and save untold millions of lives each year. However, their usefulness is threatened by the development of resistant strains of bacteria and fungi, which can cause untreatable infections. Preventing infections in the first place is a foundational step toward combating resistance, and every infection prevented is one less instance of antibiotic use, and using fewer antibiotics significantly reduces the risk of these resistant infections. However, these pathogens are continually evolving new ways to evade the drugs designed to kill them. Antibiotic resistance threatens our ability to treat and prevent infections, and as indicated in the 2019 CDC Antibiotic Resistance Threat Report, we know that more than 2.8 million illnesses and 35,000 deaths result from resistant infections each year in the US, and these healthcare costs are commensurately extreme. But there's a positive side. Our efforts to reduce the effects of antibiotic resistance are working, and from 2012 to 2017, the overall number of US deaths from resistant infections fell by 18%, and the number of US deaths from resistant infections in hospitals fell by 30% as a result of our efforts to prevent infections and control their speed. However, antibiotic resistance continues to harm too many Americans, and worrisome trends are emerging, including the discovery of new resistant pathogens such as Candida auris and an increase in resistant Neisseria gonorrhea infections. In 2019, the World Health Organization named AMR, antimicrobial resistance, among the top 10 threats to global health, and the CDC included gonorrhea as one of the 5 pathogens that are urgent public health threats due to AMR and requiring urgent and aggressive action. As for the other STIs, such as chlamydia and syphilis, AMR is much less common, but its resistance to these infections still exists and may increase over time. So a little bit more about a One Health approach. We know that germs can move between hospitals and communities through people, and within communities, germs can spread between people, the environment, and animals. And these germs continue to spread and develop new types of resistance, and progress may be undermined by some community-associated infections that are on the rise. As such, the US government effort towards AMR takes a true One Health approach, recognizing this interconnectedness and thus promoting collaboration and communication among the different agencies on the critical issue of AMR. So I'll tell you a little bit about the government response. So we've had a comprehensive and coordinated suite of actions to combat antibiotic resistance. They're implemented by a diverse set of agencies using a One Health approach. While federal efforts to address resistant infections go back decades, the current form of this response was instigated largely by the 2013 CDC report on antibiotic resistance, which was later updated in 2019, and the President's Advisory Council on Science and Technology as well helped contribute to the CARB effort as well. Let's see, there was a An executive order was issued in 2015 that helped combine these efforts all together and helped the creation of the Interagency CARB Task Force and the Presidential Advisory Council on Combating Antibiotic-Resistant Bacteria. The CARB Task Force then reacted to a strategy that was issued in 2014 by creating the Action Plan that was issued in 2015 with its now renewal in 2020. So I'm going to tell you a little bit about the Presidential Advisory Council on Combating Antibiotic-Resistant Bacteria, which is entirely distinct from the Interagency Federal Task Force. The Presidential Advisory Council is just that, a federal advisory committee that provides advice and recommendations to the Secretary of Health and Human Services. As I mentioned, we were authorized by executive order along with the creation of the Interagency CARB Task Force. And we were reauthorized actually as recently as of last year by our inclusion into the Pandemic and All Hazards Preparedness and Advancing Innovation Act of 2019. And the significance of that particular act is the fact that it puts AMR in a biodefense context with public health security implications. Our council also utilizes a One Health approach by virtue of the membership of the council. We've got human health experts and animal health experts, and a large portion of the membership from the CARB Task Force actually serves as ex officios on the council to help inform these external members as they develop their recommendations for the secretary. So just briefly, you'll see our new duties under PAPA. There's some nuances from our executive order authority, but I want to emphasize the inclusion of education here and international coordination as well as we take on our tasks. Next, you'll see how the timeline of how our reports and recommendations have been issued. And I'm going to discuss briefly today the most recent report we've had, which was tasked by the Secretary of Health and Human Services to identify priorities for consideration for their inclusion into the next iteration of the National Action Plan for Combating Antibiotic-Resistant Bacteria, which was issued by the CARB Task Force, which is the federal entity separately. And just a little bit about the council for all of you that don't know about us. We are, again, a federal advisory committee. We hold 2 to 3 meetings per year. The council recommendations, again, are to inform the Secretary of Health, but they're accessible and available to the public. If you visit our website here on hhs.gov/PACCAR, you can access all of our meetings since our inception in 2015. All of the PowerPoints are also provided, and we're a resource for anyone and everyone that wants to learn about a little bit more about AMR. We've tackled a slew of presentations and topic areas also globally, so please do check us out and send us your comments if you have any questions at all at carb@hhs.gov, and our council members are obligated to see those and review those as part of their function as committee members. So I'm going to switch gears right now and transition a little bit into the CARB Task Force, again, which is a separate federal interagency entity that formally works on the CARB effort on behalf of the U.S. government. So in parallel to the council's operations, the CARB Task Force pulls together the relevant agencies across the One Health spectrum to promote collaboration and communication. And these, that you see on the slide, are the agencies represented on the CARB Task Force. We're co-chaired by the Department of Defense, the Department of Agriculture, with HHS at the helm. The Office of the Assistant Secretary for Planning and Evaluation, or ASPE, within the Office of the Secretary, serves as the federal coordinator for the task force. And our PACCAR, the committee that I manage, is coordinated by the Office of the Assistant Secretary for Health, or OASH, which is a sister division within the Office of the Secretary. And we all collaborate and coordinate very closely on all of our tasks. So the 2015 National Action Plan for Combating Antibiotic-Resistant Bacteria that was issued by the Interagency Task Force that I just mentioned, the slide comprised of all of the agencies that you just saw, set in motion the nation's coordinated federal response to antibiotic resistance, one of the greatest global health threats of our time. The National Strategy for CARB is the foundational document that guides the task force's work, and it is organized around these 5 goals that you see. And these goals, just in shorthand, are on infection prevention and stewardship, surveillance, diagnostics, treatments, plus the international collaboration on CARB research and development. And major progress has been made since the first National Action Plan was launched in 2015. And just to pick some highlights, the U.S. government worked with partners on all of these achievements, including the Antibiotic Resistance Lab Network, CARB-X, and which pursued alternatives for antibiotics in agriculture and obtained hundreds of commitments to global action through the 2018 AMR Challenge. The task force has reported on these advances each year and will be publishing a comprehensive summary of progress in the forthcoming Year 5 report, which may be issued towards the end of October. Knowing that 2020 was not the end of the story and that the first National Action Plan was a foundation to build upon, as I mentioned in the previous slide, in the fall of 2018, the CARB task force pulled together 125 federal experts crossing the One Health spectrum and drew from the PACCAR's report on public input as tasked by the Secretary to the Presidential Council. The CARB task force reviewed their efforts thus far and what they could anticipate coming in the future. And this is an excellent example of where rubber hits the road, where you have the collaboration between the task force and the council, where input from a federal advisory committee is actually inserted into a document issued by the US government. So switching back a little bit to the council in particular and the PACCAR, I'm going to talk a little bit about the actual task from the secretary. And the question itself was to identify priority areas for the next National Action Plan 2020 to 2025. And overall, the council's input supported the continued efforts of the original National Action Plan and recommended additional attention to 3 particular areas that were already included, but the council wanted them to be further emphasized. And those are the rise of the drug-resistant fungi, AMR in the environment, and U.S. global leadership in combating AMR across all 5 goals of the National Action Plan. And lastly, the resulting CARB National Action Plan for 2020 to 2025 presents a set of coordinated strategic actions to change the trajectory of antibiotic resistance in the next 5 years. The new plan coming out maintains the original 5 goals as set by the national strategy and adds on new objectives and targets. It's important to note that some of the objectives in the new plan build on existing programs and policies, while other objectives reflect new activities by the agencies. Implementing all of the activities outlined in this plan will depend on the availability of resources and capacity. The new National Action Plan continues to reflect One Health and to prioritize infection prevention and control, the appropriate use of antibiotics, and support for innovative new products. The task force work since 2015 has clarified their understanding of the challenges inherently in collecting and analyzing data. So the new plan continues and enhances the focus on collecting data and turning it into useful information. They've also developed an updated measurement and reporting strategy, setting quantitative targets whenever possible. And they'll be updating those targets in the annual reports as needed. And similar to the last report, the issue of resistant STIs remains a priority throughout the report to come. So lastly, I just want to circle back to the PACCAR, the Federal Advisory Committee that I manage, and that is the public's platform for providing input and comment. You're welcome to send us any emails that are directly related to antibiotic resistance to carb@hhs.gov. We encourage you to send any information or anything that you'd like for the council to consider regarding the topic of AMR. And also you can stream us live during our public meetings. Everything about the council is available on hhs.gov/PACCAR. And with that, I thank you and turn it over back to Dr. Bolin. Thank you so much. Anyone there? Well, it seems like we lost our role, and so Carol, do you want to go ahead next and talk about the
Sure.
STI?
So good afternoon, good morning, everyone. This is Carol Jimenez, and I'm going to, oh, here's Gail. Sorry. So
Okay.
I was just about to introduce Harold. I'll turn it back to you.
Okay,
Gail.
I'm going to not figure out about the camera being on because it keeps kicking me off. Thank you, Carol. We're doing a tag team here. So first I would like to say that we do have the question and answer page open, and we will be taking questions at the end of this session after 2 more speakers. So we encourage you to send your questions in through the Q&A. And we'll move on now to our next speaker who is joining us by phone. So Harold Phillips works in the Office of HIV/AIDS and Infectious Disease Policy in the Office of the Assistant Secretary for Health at the Department of Health and Human Services, where he has been for a while the Senior HIV Advisor and more recently the Chief Operating Officer for Ending the HIV Epidemic, a Plan for America. And Harold received his master's degree in urban and regional planning from the University of North Carolina at Chapel Hill and has an undergraduate degree from Kalamazoo College in Michigan. So Harold, if you can join us, we will advance your slides for you as soon as you let us know when we should go to the next slide. So welcome.
Thank you, Gail, and good afternoon, everyone. Hopefully you are all able to hear me and we'll be able to see the slides as well. So thank you for the introduction, Gail, and I'm also very happy to be here with you all as well as my colleagues from OIDP to talk about our work on the National Strategic Plans. And I'll focus my talk on the HIV plans, but also hopefully set the stage for Carol Jimenez, who will talk about the STI plan, but hopefully I'll give you a sense of how we've tried to create some synergies between the HIV plan, the viral hepatitis plan, and the STI plan that will help us in addressing this endemic. So next slide. So I'm hoping that the slide that you all see right now talks about HIV diagnosis and shows the progress that we've made in the United States since the 2000s, but also how we have plateaued. And also this graph is important, I think, because it also shows sort of where we were in 2010 with the release of the initial HIV strategy. And our progress as a country, which has stalled at where we've had sort of consistency around 38,000 new transmissions in the United States for the last couple of years, which, if we go to the next slide, shows sort of the geographic breakdown for that, which includes the 48 counties and 7 states with substantial rural HIV burden, which also include D.C. and San Juan, Puerto Rico, where we have about 50% of these new diagnoses. Now, these are the areas which, under the Ending the HIV Epidemic Initiative, we call the Phase 1 jurisdictions. And while our National HIV Strategic Plan will cover the entirety of the country and also be a plan where we call for federal, state, and local coordination, EHE becomes the HHS operational implementation of efforts to end the HIV epidemic within the United States. EHE also calls for us to think about how we use the data, the science, the tools, as well as sort of the political will to end the HIV epidemic in the United States by first focusing on what sometimes we call the 57 jurisdictions, or the G57, which are those 48 counties and 7 states. By focusing and targeting efforts here first, where there is more than 50% of the new transmissions are located, we hope to be able to bring that number down while also paying attention and monitoring what's happening in the Phase 2 jurisdictions, and also helping them as part of our Phase 2 implementation efforts to apply the best of the science, some of the lessons learned were from Phase 1, as well as paying attention to what we call the EHE pillars. So that sort of, I think, sets what we sometimes think of as sort of the framework and the context for the EHE initiative. But within that, there is overall the National Strategic Plan, the National HIV Strategic Plan itself. Next slide. So with the HIV plan sort of being the granddaddy of the strategic plans overall, because it's been in existence for over 10 years. There's been a lot of experience in both its development and also the structure of the plan itself. This plan, it's important to note, builds on the previous iterations of the plan and its existence. So we didn't scrap everything that was in previous plans, but yet use that as sort of a stepping stone to this one. The other thing that I think is very important about this strategic plan is that this is the first plan that acknowledges our ability to end the HIV epidemic in the United States without a vaccine. Ending the HIV epidemic by applying 30 years' worth of expertise in both implementation science, 30 years of surveillance, in the ability to collect data and understand that data and drill down and truly understand and working toward understanding better disproportionate impact of the HIV epidemic on other communities and populations and minority groups. Our ability to continue research into which interventions and models work best or differently within populations, within clinics, and within different healthcare settings. And so applying that differently will hopefully get us to a different result. But also, there were, throughout the engagement of the public in the development of the plan, hopefully you can see on the screen some of the previous steps that were taken to not only help enhance and build this version of the HIV strategic plan, but also when it comes to viral hepatitis, being able to use some of those same processes in its development as well. Next slide. So similar in approach and thinking about both our audiences and how we would continue to build the plan itself. The National Strategic Plan, like I said, will serve as a whole of society approach, engaging federal, local, and state and local and tribal key players and stakeholders. It's our hope and our desire that as the plan is being developed, not only have we taken the input, but that these key stakeholders and partners will also see themselves within the plan as well. The other thing that I think the OIDP staff is quite proud of in its development is the collaboration and the alignment that I think has happened for perhaps the first time in the development of the HIV plan, the STI plan, the viral hepatitis plan, and as Jimenez talked about, so there will be some aspects of the vaccine plan that also will kind of mirror some of our efforts as well. Next slide. So to talk a little bit about sort of our plans and sort of the overview, again, it will be a 5-year plan, although we will have targets to 2030. And this is important because the Ending the HIV Epidemic Initiative is a plan that goes until 2030. And so as part of the EHE plan, there is both the 5-year goals, which call for a 75% reduction in new infections by 2025 and a 90% reduction within 2030. And as I mentioned, sort of being plateauing at somewhere between 36 to 38,000 new infections of HIV on an annual basis, when we talk about a 90% reduction by 2030, we're talking about 3,000 or less new HIV infections in the United States. And in so doing, one of the other things that we're very excited about is the alignment of the indicators within the HIV plan with both our Healthy People 2030 as well as alignment with EHE. And the next slide. While the National Strategic Plan has its indicators, which include not only the 6 EHE indicators, but also an indicator on stigma and an indicator on homelessness. homelessness because of the impact of housing and housing status on a person's HIV health outcomes. So really, the adoption of the 6 EHE indicators, along with a stigma and discrimination indicator and a homelessness indicator, we think we will be able to definitely measure our progress on the plan, as well as the fact that with EHE, for the EHE jurisdictions, those 57 that I mentioned, each of them has where we are right now at baseline, as well as the targets for 2025 and 2030. And so for the first time in the United States, we actually have targets that are associated with the indicators, and with the AHEAD dashboard, which you can visit at hiv.gov, it allows us to sort of see and monitor our progress and calls for a new level of transparency when we're thinking about the HIV epidemic in the United States. Next slide. The next slide talks about sort of our HIV plan and our wildly important goal of reducing new HIV infections by 90% by 2030, and the additional indicators that I mentioned, as well as the alignment with Healthy People 2030. Next slide. And I will go a little bit faster because I'm afraid that I may be running out of time very quickly. So the HIV vision statement, again, this vision statement builds on previous vision statements that were in the National Strategic Plan and Strategy in the past. As we move toward that vision, I think, again, it's very important to think about our overall indicators and the targets that we have as well, and really thinking about our systems of care. One of the things that I think makes EHE work as an operational plan for HHS and ending the HIV epidemic that is complementary and supports the National Strategic Plan is our ability and the recognition that the current HIV system that we have, while we've had tremendous progress over the 30 years, that progress has not been equal for everyone. And EHE gives us a chance to be innovative and talk about what Admiral Giroir has called disruptive innovation, to be able to reach and increase access for populations that have been left behind as we've developed these systems over the 30 years. Next slide. Our overall goals for the HIV plan, and I've included the viral hepatitis goals on this slide as well, just so you can sort of see an example of when we talk about sort of the alignment that exists between the goals. And my colleague Carol will talk about the STI plan, so I didn't want to steal her thunder on any of that when she reveals that. But hopefully you can see by this slide the alignment between the HIV goals and the viral hepatitis goal. One important goal that I will talk about on this slide is Goal 4, achieving coordinated efforts that address the HIV epidemic among all partners and stakeholders. And this is just one of the areas, and I also think that within Goal 3, reduce HIV-related disparities and health inequities, really looking at where is that intersection between where the syndemic really and truly sort of comes into play, and thinking about new partnerships and strategically who are the stakeholders that we can work with in a different way. And I think that you will see that sort of alignment across the plans, which really and truly we hope that as we move toward the development of the work plans and the activities by the federal, state, and local partners in all of this, that we will see the formation and creation of new partnerships to support not only our HIV goals, but our STI goals as well. Next slide. In terms of timing for release, we've had the OIDP draft review. The plan will go to the Federal Steering Committee in early October. I think it's October 8th, as a matter of fact. After that, we will be doing another set of revisions, and we are looking to do an FRN release, hopefully a Federal Register Notice release, hopefully by the end of October, early November, all things held constant and continuing to move forward without any glitches. And we are hoping to get this plan released sometime in December. Then we will begin sort of our communications and marketing aspect of the plan and the plan's release, as well as beginning the development of the federal implementation work plans within early 2021. So with that ends my presentation of the slides, and I look forward to questions and comments after the end of the other panelists. Thank you.
Okay, thank you, Harold, very much. And we're now going to move to our next speaker, Ms. Carol Jimenez, who's Deputy Director for Strategic Initiatives in the Office of Infectious Disease and HIV/AIDS Policy in the Office of the Assistant Secretary of Health at HHS. She's been the lead in developing the first ever STI National Strategic Plan. And we look forward to hearing about that today from her. She does hold a law degree from Georgetown University and a bachelor's degree from the University of Rochester. So thank you, Carol.
Great. Thanks very much, Dr. Bolin. And thanks to my colleagues from OIDP, Dr. Jimenez Musmar and Harold Phillips, for sharing some of the work that they help lead. I'm going to go through pretty quickly. At the outset, I just want to share with you, I think probably many of you on this webinar already know that we have posted a Federal Register notice with the opportunity for public comment on the draft STI National Plan. And it's a short notice because we do want to get this released in 2020. And we for some time deferred engaging our federal partners so that they could work full time addressing COVID and not get distracted by other things as important as other epidemics are. So I'm going to talk about that in a few minutes. But first, just want to give a little bit of an overview of the STI plan and the work we do. And I hope that by giving you this overview, it will actually make your jobs easier in reviewing the STI plan, which is posted on our website, www.hhs.gov/STI, and that information is in the slide deck. So here's a slide about our office. We cover a lot of topics. We cover HIV, viral hepatitis, STIs, AMR, which Dr. Musmar spoke about, blood and tissue safety availability in the US, vaccines. We are doing a lot of work on COVID. We're a busy, small but busy office. I think by this time, most people are familiar with the term the syndemic. We have taken an integrated approach to the different epidemics that do co-occur, both in related by cluster and people, place, and time with respect to these. So for purposes of the national strategic plans that we are leading, we are treating HIV, STI, hepatitis, SUD, substance use disorders, and also stigma and social determinants of health. I should say stigma, discrimination, and social determinants of health, all as one syndemic. And as Harold mentioned, and you'll see throughout this, we really do take an integrated approach to all of this in all of the strategic plans. Here's a handful of the strategic plans that we are leading development of, although I will point out we did not lead the opioid strategy, but it is integrated into the work that we're doing on the other national strategic plans. So the scope of the STI plan, and keep in mind, this is the first ever, and there will be more iterations that may be a little bit more broad. We focus on 4 of the STIs that have the greatest impact on the health of the nation: chlamydia, gonorrhea, syphilis, including congenital syphilis, and human papillomavirus. It, like the HIV plan and also the viral hep plan, is a 5-year plan, but we have 10-year targets, quantitative targets. And we do that because we really don't think we can accomplish what we want to accomplish for the nation within 5 years. HIV and viral hep are elimination plans. The goal is to eliminate them as a public health threat by 2030. With respect to STIs, because the trajectory is so dramatic upwards, which is the wrong direction we want to be going for STIs in this nation, we have to first slow down the trajectory before we can reverse it. So this first ever STI plan is not an elimination plan, but I do think we have pretty aggressive 10-year targets. And along with the 10-year targets, we also put forth annual targets to help us measure as we go. Development has been an iterative process with a pretty broad and deep federal steering committee, leadership from across HHS, from across other federal departments. We have met monthly for more than a year. We established 5 subcommittees with SMEs from all of the different agencies. They met bi-weekly for a very long period of time. And it has gotten us to where we are today, that we have a full draft STI National Strategic Plan that we've shared with you on the internet. Here's just a slide similar to what Harold showed on viral hep and HIV. We had a pretty robust public comment process at the outset, so that we did take public comment into account. We analyzed it, we shared it with the steering committee, with the subcommittees, and we also took the extra step of compiling all the comments that pertain to the work of any particular agency and shared those with them so that they could take it into account as they move forward with the work that they do. Harold already talked about the integrated approach that we're taking in all 3 plans. We spent a lot of effort to both have an integrated approach to this endemic, and as I, in my very scientific lingo, like to call one-stop shopping, no wrong point of entry, wherever someone accesses the healthcare system. And as we all know, it may be someone's only time accessing the healthcare system. We can't rely on the fact that they're going to keep coming back. So we want to make sure that we screen and link to care at that any point of entry. We have made a great deal of effort to align the visions, the goals, the objectives, the strategies. We have matched them up and looked at them in extreme detail and at a high level view to see where it makes sense to align. And of course, there are places where it doesn't make sense to align, and we have different strategies and objectives. And I'll just give an example. In the goals, for instance, for viral hepatitis, we have a goal that focuses on data and surveillance because that's such an issue in the viral hep world, whereas we don't have that in HIV. In STIs, we have a goal that focuses on innovation and research, so that, help promote a focus on developing vaccines and novel point of care diagnostics, and novel treatments, so that we can get past the antimicrobial resistant issue that we have with gonorrhea and that we're concerned about for other infections as well. In working on aligning all of this, we have worked with the folks that developed Healthy People 2030. Healthy People 2030 was released, I believe it was August 18th. And as we release each of the national strategic plans, Healthy People 2030 will update its targets to align with the targets in our plans. The objectives are already aligned. Here's the vision and the goals of the STI plan. Pretty similar to what Harold shared with regard to HIV and viral hep, but again, as I just mentioned, they are tweaked a little bit differently. Here's the structure of the plan itself, and this isn't necessarily the document that's posted, but within the document, the guts of the plan. We have a vision. Under the vision, we have 5 goals. And on this slide, it just gives an example so you can see how it flows from under each other. Under each goal, we have objectives. Under each objectives, we have strategies, a more granular level of recommendations how to achieve the goals. We, the federal government, will, after the plan's released, develop a federal implementation plan in which we put forth our commitments within our own purviews as to what we are going to do in the next 5 years to reach the targets of the STI plan. We hope that you, as stakeholders at all different levels and with different purviews, will take the STI plan and use it as a roadmap for your own efforts. Also within the STI plan, we identify what we call priority populations. I can tell you that personally, I'm not really a fan of that nomenclature, but we use it as a shorthand to refer to disproportionately impacted populations. And for the STI plan, for us as the federal government, we do it based upon nationwide data. But we also explain the methodology we use so that if you have a different purview, if you're a state, if you're a local jurisdiction, a tribal nation, a stakeholder with a particular purview, such as the Veterans Administration, you can take the methodology and figure out what populations that you serve are disproportionately impacted so that you can focus your limited resources to have the highest impact. And then we have indicator measures. How do we measure progress on all of these strategic plans? We take indicators that already exist because we can only use existing data to measure progress. We stratify them to measure disparities. And then we also recommend a few areas in which we think additional indicators need to be developed. Here's just a snapshot of the organization of the document itself. So you have the guts of the document in section 3, the STI National Strategic Plan, which I just talked about, but there's a lot of introductory material laying the foundation for why we need this plan, an overview of each STI, how we're going to hold ourselves accountable, and then a lot of the development of the plan and the methodology for the indicators and priority populations are in appendices. So here, the thing that I think most folks are interested in, the opportunity for public comment. If you go to our website, it links to the Federal Register notice, and the STI plan itself is also posted. All of this information is in the Federal Register notice, but comments must be submitted electronically to our email address, and they must be submitted by 5 p.m. Eastern Time on October 1st to be considered. We will not accept late comments because we are moving as fast as we can to get this released in 2020. We also give some areas in which we're looking for feedback. We really are looking for high-level feedback. Is there anything critical? Are there any critical gaps that we're missing? And is there anything in the goals, objectives, and strategies that really causes you concern? And if so, please let us know what it is. So we are very excited to be at this point. Huge thanks to so many federal partners across HHS and other federal departments, to you, the stakeholders who already submitted comments at the outset when we were developing the plan and who have been in touch and been very supportive of our efforts. And we certainly look forward to seeing your comments and hearing what you have to say and incorporating them into the final version that will go through the formal clearance process before the document gets released. Back to you, Gail.
Thank you, Carol, so much. So we unfortunately get cut off in 2 minutes. So we're going to quickly go through some questions we've received. There was a common question both for the STI plan and the HIV plan, Carol and Harold, is they wanted to know specifically how, are you planning on getting input from the community members who are at, disproportionately affected by STIs? And I think, Carol, you just went over that for the purposes of the STI plan.
It'll be the same for all 3 plans.
Okay. So
and we are making a big effort to send the information out to all of you and asking all of you to share it with your communities as well.
Okay. Another question for Harold is, briefly, Harold, could you expand on how stigma and homeless indicators will be measured?
So that is something that we are still working through, and we'll also take input from the steering committee as well as input from the Federal Register notice as individuals take a look at that. So more to come on that piece. Okay. But there are data sets. We haven't quite finalized which data sets we will be using, but please comment.
Okay. And Jumana, I'm curious if you've had 5 years into the CARB initiative, if you could name the top 2 successes you would say from your vantage point of what we've been doing with antimicrobial resistance in the country. Anything come to mind?
Yes, sorry, I'm having.
I know it's hard.
My apologies. Yes, actually, I mean, we've had tremendous successes. You know, there are a couple of progress areas that I would like to emphasize for folks, just so they know the impact. So, with the launch of CARB in particular, it's a biopharmaceutical accelerator. There's been over $230 million in U.S. government investment, complemented by another $220 million in additional donor funding for early stage antibacterial product development. So we've had a lot of progress on that and encouraging startup companies to remain in the area, but of course, a lot more needs to continue. And the other thing I wanted to mention was about the AMR challenge that is led by CDC and OGA, where we've had 350 commitments from partners across 31 countries for the antimicrobial resistance challenge. And it's been an ambitious global initiative to date. The US government has led global action from a broad range of sectors and stakeholders to combat resistance. And we're hoping to achieve that once again come next year.
Okay, great. Well, we're going to have to wrap up. We still have some questions we can't get to. I encourage you to submit comments through the Federal Register and the HHS website. And thank you so much for your attention, and a big round of applause. I don't know if we can do this remotely for our three great speakers today, Jimena, Harold, and Carol. So thank you very much.